Hello, my name is Matthew Miller. I am an attending breast imaging radiologist at the University of Virginia, and I will be presenting my project entitled Factors Associated with Patient-Reported Deterrence to Adjunct Breast Cancer Screening in Women with Dense Breasts. We have no disclosures. Breast cancer, as we know, is the most common non-skin cancer in women in the United States, with over 260,000 women diagnosed annually and approximately a 12% individual lifetime risk for developing breast cancer. Mammography is the only screening examination which has been proven to reduce breast cancer mortality, but it has been well established that mammography is less sensitive in patients with dense breast tissue. This decreased sensitivity of mammography in women with dense breasts is compounded by the fact that these women have been shown to be at increased risk for breast cancer. To help address the need for more sensitive breast cancer screening in women with dense breasts, several new screening modalities, including abbreviated MRI, contrast-enhanced spectral mammography, or CESM, handheld breast ultrasound, and automated breast ultrasound, have been developed and are in various stages of clinical validation as adjunct screening modalities for women with dense breasts. However, the successful implementation of any new adjunct screening recommendations will not only depend on the clinical performance characteristics of the exam, such as sensitivity and specificity, but will also depend greatly on patient preferences and attitudes toward the experience of undergoing the exam. In order to better understand patient preferences and attitudes toward adjunct breast cancer screening, we previously conducted a prospective study, a survey of women with dense breasts who presented for screening mammograms. Among other things, we found that the most commonly cited deterrents to adjunct screening included cost, cited by 69% of patients, pain, cited by 35% of patients, and a concern that additional procedures could result, cited by 32% of patients. When asked to select between three hypothetical screening exams, we found our patients to have a strong preference for more sensitive screening tests, with 95% choosing a more sensitive screening exam even if this would involve higher cost or IV contrast administration. In our present study, we sought to identify patient characteristics associated with patient concern regarding potential deterrents to adjunct breast cancer screening and patient preference between hypothetical screening exam choices. Survey response data from our recent prior study of 508 women with dense breasts were aggregated post-hoc with data from the medical record, including age, race, Tyrer-Cuzick lifetime breast cancer risk score, and family history of breast cancer. Patient addresses were also geocoded, and federal census block and tract data were used to impute socioeconomic data, including median household income and health insurance status for each patient. Univariate and multivariate logistic regression analyses were then conducted to evaluate for associations of patient characteristics, the predictor variables, with patient survey responses regarding deterrence to adjunct screening and hypothetical screening exam preferences, which were the outcome variables. We first performed logistic regression analyses looking for patient characteristics associated with patient-reported concern about each of the deterrent factors. As you can see on this example table from our analysis of patient concern about cost, the patient characteristics we used as predictor variables were dichotomized where possible and included age, race, family history of breast cancer, Tyrer-Cuzick lifetime risk for breast cancer, perceived personal risk for breast cancer, having been previously called back from screening, having previously discussed breast cancer density as a risk factor for breast cancer with a healthcare provider, and patient confidence in the sensitivity of mammography in dense breasts. The outcome variables included patient-reported concern about the following deterrent factors: adjunct screening exam cost, time commitment of exam, pain associated with the exam, possibility of additional imaging being recommended, possibility of additional procedures being recommended, radiation exposure, and possible IV contrast allergic reaction. Logistic regression analyses were then also performed to look for patient characteristics associated with hypothetical screening exam preference. As a reminder, exam preference responses were dichotomized into two groups: the group who preferred a standard screening exam and the group that selected a more sensitive exam, either with an additional cost or with added IV contrast administration. As you can see from this table, this analysis included the same patient characteristics as used in the previous analysis as predictor variables. These are listed in the white font. This analysis also included additional predictor variables seen in yellow font, which included patient-reported concerns about each of the deterrent factors: cost, time, pain, additional imaging, additional procedures, radiation, and IV contrast, as well as a previous history of IV contrast administration. Finally, we also tested whether adding our imputed socioeconomic data increases the accuracy of the multivariate models for each of the outcome variables assessed. One key finding of our study was that patients with a better understanding of the low sensitivity of mammography in dense breasts are less likely to be deterred from adjunct screening exams by concerns about time or additional imaging that may result, and are more likely to select the more sensitive hypothetical screening exam. Another key finding was that none of our predictor variables was independently associated with patient concern about exam cost, the most commonly cited deterrent to adjunct screening. Interestingly, socioeconomic variables did not improve model prediction when added to our model for exam cost, suggesting that financial concerns about adjunct screening are not confined to one socioeconomic group. In fact, socioeconomic variables did not contribute to any of the predictive models generated for any of the outcome variables we evaluated. This is in contrast to some prior studies which have found socioeconomic variables to affect patient screening behaviors, but this difference may be related to our using imputed socioeconomic data from census records rather than patient-reported socioeconomic data. We also found that younger patient age is independently associated with lower concern about additional imaging or additional procedures resulting from an adjunct screening exam. On univariate analysis only, we found an association between younger patients and a higher concern about exam cost and time commitment, but a lower concern about pain and IV contrast. Considered together, these findings suggest that younger patients may be less concerned about the physical impact of an adjunct screening exam, such as pain or additional imaging, and more concerned about the impact the exam has on the rest of their life, such as financial and time impacts. We found that a family history of breast cancer or a high perceived risk for breast cancer are both independently associated with a lower concern about potential additional imaging resulting from adjunct screening. Interestingly, this association is independent of actual breast cancer risk, as determined by the Tyrer-Cuzick Lifetime Risk Score. This suggests an opportunity across all risk groups to reduce patient concerns about adjunct screening by helping them to have an accurate understanding of hereditary breast cancer and an appropriate perception of their personal risk for breast cancer. Previous studies have suggested that conversations with healthcare providers about breast density can help patients with dense breasts obtain appropriate adjunct breast cancer screening. In our study, we found that simply having discussed breast density with a healthcare provider was not independently associated with a lower concern about any of the deterrent factors to adjunct screening. However, as described earlier, we found that having an accurate understanding of the limits of mammography sensitivity in dense breasts was associated with lower concern about several deterrents. These findings highlight that only high-quality patient-provider interactions in which true patient education about breast density occurs are effective in decreasing patient concerns about adjunct breast cancer screening. Finally, our data also confirm several prior studies in showing that having a history of being previously called back from screening exam for diagnostic workup is not associated with a negative attitude toward screening exams. Our study has a few limitations. Our patients were women with dense breasts and were all imaged at one institution, so the findings of this study might not be generalizable to other populations, including women with non-dense breasts. In addition, our socioeconomic data were imputed from population census data rather than directly solicited from patients, and are therefore more reflective of the economic situation of patient's geographic neighborhood than of the patient. However, this is one reason why we built our models without socioeconomic data first, using patient-specific data only, before then adding the population-based socioeconomic data to look for increased accuracy of our models. In this study, we found that patients who are younger have a higher perceived risk for breast cancer, or who were more informed about the decreased sensitivity of mammography in dense breasts, cited fewer deterrents to adjunct breast screening. We also found that none of the patient characteristics we tested were associated with the most commonly cited deterrent to adjunct screening, exam cost. Our study therefore suggests that educating younger women about their personal breast cancer risk and the limits of mammography may be effective in increasing adjunct breast cancer screening participation in women with dense breasts. Here are our references, and thank you for your time.